Good morning. My name is Josh Holley. I'm an otolaryngologist based out of New River Valley Medical Center, and I want to take some time to discuss some updates about the diagnosis and treatment of rhinosinusitis. I'll start with a summary slide first. The most important thing to remember about sinus infections is that only 0.5 to 2% are complicated by bacteria. For that reason, the primary recommendations for treatment are supportive. Watchful waiting is the primary recommendation, even in patients that have had more than 10 days of symptoms. If antibiotics are recommended, amoxicillin plus or minus clavulanate is the primary antibiotic recommended for our penallergic patients, doxycycline or respiratory fluoroquinolone. Remember, though, that in patients without penicillin allergy, outcomes are comparable with both amoxicillin and amoxicillin with clavulanate. I'll share a little overview on this slide. Despite guidelines that encourage judicious antibiotic use for acute rhinosinusitis, antibiotics prescribed in about 82% of visits. If you look at our Carillion data, sinusitis is the second most common diagnosis for which antibiotics prescribed, leading to over 16,000 antibiotic prescriptions. Again, remember, only 0.5 to 2% of sinus infections are complicated by bacteria. If we're just looking at what's coming out of the nose, purulent discharge alone is not enough to distinguish between bacterial and viral infections. And lastly, symptoms of sinusitis typically peak around day 3, but can last for up to 14 days. So, viral rhinosinusitis, aka sinus infection. We all know that viral illnesses are self-limited, characterized by cough, sneezing, runny nose, sore throat, nasal congestion. The incidence of viral rhinosinusitis is quite high. The average adult will experience 2 to 5 episodes a year. The symptoms typically peak at day 3, but can last up to 14 days, and antibiotics are ineffective in the treatment of viral infection. Recommendations for treatment are palliative, so pain control using Tylenol or ibuprofen, antihistamines, mucolytics, cough suppressants, topical steroids, and even oral corticosteroids. Oxymetazoline, also known as Afrin, can be very effective for the first several days. You just don't want to encourage usage past day 5 because there's a greater risk of rebound congestion or rhinitis medicamentosa. So how do we diagnose bacterial sinusitis? And how can we tell the difference between bacterial sinusitis and viral sinusitis? The short answer is you can't. It's more about duration of symptoms. Again, to diagnose a, quote, sinus infection, end quote, requires 3 cardinal symptoms. That is nasal congestion, discolored nasal drainage, facial pain or pressure, often associated with reduced sense of smell. Symptoms persist without improvement for 10 days beyond the onset of the upper respiratory symptoms, or symptoms of acute rhinosinusitis that worsen within 10 days after initial presentation, the classic double worsening. Again, remember, discolored nasal drainage is a sign of inflammation. It's not specific for infection. And the coloration of the mucus is related to the presence of neutrophils, not bacteria. Remember, if you look in the nose and it looks normal, that is inconsistent with a sinus infection. So we spent several slides talking about what is a sinus infection, and this slide's more about what's not a sinus infection. Patients who present with facial pain alone without other cardinal symptoms are unlikely to be suffering from primary sinus pathology. In fact, a 2007 study at Mayo Clinic showed that out of 100 self-reported sinus patients, only 3 had sinus pathology identified. Bigger studies have shown that up to 98% of sinus headaches are migraines. Nasal obstruction alone is inconsistent with a sinus infection. Throat clearing, chronic cough, dizziness, vertigo, these are not classic symptoms of sinusitis. So you've made the diagnosis of sinusitis. What are the evidence-based recommendations for treatment? As we learned at the beginning of the talk, only 0.5 to 2% of infections are complicated by bacteria, so antibiotics are rarely indicated. The evidence-based recommendations for treatment are supportive. Nasal saline irrigation is probably best, either isotonic or hypertonic. Decongestants, topical, probably better than systemic. Topical nasal steroids, NSAIDs for pain control. In severe cases, you could consider oral steroids if no contraindications. Guaifenesin probably doesn't provide much benefit. As far as imaging, there's no indication for imaging unless you expect or suspect extra sinus involvement, but really encouraging patients that conservative treatment is better than antibiotics in general. So older guidelines recommended treatment with antibiotics for sinusitis if symptoms were present for more than 10 days or worse after 5, the classic double worsening. Based on the limited number of bacterial infections involved with acute sinusitis, the guidelines have currently been updated. Watchful waiting should be the default initial recommendation for patients with acute sinusitis. This strategy is universally adopted across developed countries, but there are some special indications for watchful waiting. These patients should have follow-up that is assured in case they do experience worsening. And lastly, we all know antibiotics have a number of potential side effects. A little bit about antibiotics and sinusitis if we do elect to initiate therapy. Antibiotics only need to be prescribed for 5 to 7 days. Treatment failure with amoxicillin plus or minus clavulanate is very low, only 1.7%, and only 0.01% of patients ended up needing hospitalization. If the patient is on appropriate therapy and they fail to improve, we need to plan on follow-up to A, ensure the appropriate diagnosis, and B, consider a switch in antibiotics if the diagnosis is confirmed. A little bit more about antibiotics in the treatment of rhinosinusitis. For our penallergic patients, primary recommendation is doxycycline or respiratory fluoroquinolone. For everybody else, fluoroquinolones are not recommended as initial therapy because they've not shown to be any better than amoxicillin, clavulanate, and adverse events with fluoroquinolones are higher. Which antibiotics should we not use? So macrolides and Bactrim both have high risk of antibiotic resistance and are not recommended as first-line treatment. So we'll end with several slides on diagnostic challenges. I think it's important to remember that most sinus headaches are actually headaches. Matter of fact, only 5% of presumed sinus headaches are correctly diagnosed. When we see patients who represent over and over with similar symptoms, we really have to be diagnostically accurate. One big study of almost 3,000 patients showed that 88% of these patients with sinus headaches were ultimately diagnosed with migraine. And then the 2007 sinus allergy and migraine study showed that out of 100 self-reported sinus patients, only 3% had evidence of sinus disease. 86% had migraines. So why can a sinus infection and a migraine be confused? The first is because they're shared symptoms. Patients can have facial pressure, they can have pain, they can have nasal congestion. But in true sinusitis, we should see discolored nasal drainage, reduced sense of smell, nasal congestion. In migraine, typically you may see unilateral symptoms, sensitivity to light, sound, smells, nausea, and dizziness. Dizziness is rarely a symptom of true sinus disease. Because migraines and sinus infections can look very similar, I found some tools in my practice that I use to help in the accuracy of diagnosis. One is the migraine questionnaire. There's 3 questions. The first is, in the last 3 months, how disabling are the symptoms, aka headaches? Do they interfere with the ability to function? These patients are missing work, they're missing school, they're not going to family activities. Do the patients get nauseous when symptoms are present, and are they sensitive to light? If 2 out of 3 are positive, this increases the risk of migraine by 93%, and if 3 of 3 are positive, the diagnosis is 98% likely. So we'll wrap things up with this slide. The most important thing to remember about sinus infections is 2% or less are bacterial. For this reason, antibiotics are rarely indicated. 3 cardinal symptoms: nasal congestion, discolored nasal drainage, facial pain or pressure. I think reduced sense of smell is a really sensitive symptom. Supportive therapy, really encouraging supportive therapy, nasal saline irrigation, decongestants, nasal steroid sprays. Watchful waiting should be offered in patients without complications. If we're going to treat with antibiotics, amoxicillin plus or minus clavulanate for no more than 5 to 7 days, and doxycycline or respiratory fluoroquinolone for our penicillin allergic patients. Thanks for listening.